Well, hi, everyone. Welcome back to our FSHD University educational webinar series. We've created FSHDU to keep the learning going and to give FSHD families an arsenal of knowledge so that they can be their own best advocates, so you can be your own best advocate. We're focused on three departments, if you will: physical health, mental health, and research, drawing on the many resourceful and creative people we have in our community. Today, we thank Allard for sponsoring today's webinar and for supporting the education of our community to promote healthy lives. So today, from our physical health department, we welcome Bob Meier, who will speak to us about two frequently mentioned topics for the FSHD community: knee hyperextension and spinal issues such as lordosis that result from the weakening of the core muscles.
Bracing for spine and knee issues, there's a lot of lack of information about the subjects of spine bracing and knee bracing. Most of the devices I see being worn out in public are fit improperly. So I hope what we can derive from today's program is not only an appreciation for the types of braces that are out there, but especially perhaps how they should be properly fit. And so you can use this information or share it with your community. And a brace can be a great thing if it's fit right. If the brace isn't fit correctly, it tends to not work, and it tends to end up in the closet floor in the bedroom. So we're going to try and just share some ideas on the right way to fit these braces and give you an idea of what kinds of braces are available for what kind of indications. So with that, we're going to start with the spine, and we'll look at some anatomy and some challenges related to that anatomy, types of bracing, and spine bracing fundamentals. And that is the right way to use these types of devices. Then we'll do the same thing for the knee. We'll look at knee anatomy and knee challenges, types of bracing, especially for knee hyperextension, and knee bracing fundamentals there also. So that's our agenda. Starting with the spine then. If we see the spine from the front, it should be a straight line. If we see it from the back, it should be a straight line. But when we see a curve in the spine that's supposed to be a straight line, that's usually referred to as scoliosis. There can be some other indications, so we can't categorize every frontal plane curve as scoliosis, but the vast majority are going to be scoliosis. And there's very specialized bracing available for scoliosis, usually done by a certified orthotist, and that bracing is usually custom made for their specific type of curve. There are 7 specific types of scoliosis curves, and so each of those braces is custom made for that patient. When we see a person from the side, there's supposed to be a curve, a little bit of a curve here at the neck, and on the upper trunk and in the lower trunk. This is referred to as the thoracic spine, and this is the lumbar spine. So those curves are there for a purpose. They help increase the strength of the spine, they help increase flexibility, and they make the spine a better shock absorber. So the spine is a lot more functional when these 3 curves are present when we see the spine from the side. If there's an exaggerated curve up in the upper trunk area, that's referred to as a kyphosis. And there are bracing specifically for that. Very often that's associated, or can be associated rather, with osteoporosis, but it can happen from other causes also. If there's an excessive curve in the lumbar area, in the lower trunk area, that's referred to as lordosis. And that can occur due to a number of reasons, including muscle weakness or excessive muscle tightness can also cause that. So we'll look at bracing and how to try and deal with that kind of situation. And finally, there are individuals that present with a very flat back. And a lot of times those individuals are guarding. They're afraid to let go, afraid to let the curve occur in their spine. And so we have different techniques we can use to help address this kind of back posture also. So with those being the postures, we want to talk about the major muscles that help control the posture of the spine. The trapezius is a big one. It starts all the way up in the neck and comes all the way out to the tip of the shoulder, runs all the way down to the middle of the back here. So this is all the trapezius that helps control the posture of the upper trunk a lot. The erector spinae are the big muscles that run just on either side of the vertebrae, on either side, all the way up and down the length of the back. Those obviously help hold the trunk up in an upright position. Sometimes those can become weak or deficit. And finally, there are the transverse muscles. There are a lot of transverse muscles here, all the way up and down the trunk. And those also help control the posture of the trunk. And they help facilitate the motion between the shoulder going in one direction and the hip going in the other direction when we walk. So they help control this rotation component of walking. And it's thought that they play a pretty major role in helping to support a more upright posture of the upper trunk. So those all are the upper trunk posture control mechanisms. There are more built in there, but I didn't want to get into too much detail because we have a lot of material to cover today. In the front, looking at the trunk from the front, this is what my tummy looks like. I've got a six-pack. No, actually, I don't. I have a keg instead of a six-pack. But those are the muscles in the abdomen, and they help pull our trunk forward like this. These have a lot to do with spine posture, especially posture of the lower trunk. So those are very important. Most individuals with back pain, for example, have relatively weak abdominal, rectus abdominis muscles. Then there are also transverse muscles in the front of the trunk that also help control posture and help support the spine and the spinal posture. So those are the ones mostly involved in controlling the lower trunk or the lumbar posture area. What kind of bracing do we have available for these? Just some broad categories. This type of brace is referred to as a mechanical advantage brace. It's usually used just for the lumbar bracing, for the lower spine bracing. And if you see the little strings in here, those are hooked to pulley mechanism on both sides here. And so usually there's one string coming out one side, and that closes down the bottom half of this mechanism. And then a string coming out from the other side that usually controls the upper half of this block and tackle mechanism. And so we'll talk about the sequence of doing those and how tight to make them in just a minute. But this is a very effective brace for the lower trunk area, for the lumbar area, because it takes very little effort on those strings to create a lot of compression support. So very, very effective in doing what they're supposed to do. Then there are braces that you simply wrap around your back and one side closes over the other in the front here. And so when the brace is put on initially, it should be put on these pulse tabs here. They're called cinch straps. These elastic tabs should be put on right in the middle. They typically cross over one another, or they may meet in the middle. But the position is important, that they be put on in the front, just so the person gets an idea of the level of support that device is offering them. So do that on the initial closure. Then we teach people, if they tend to have more of an excessive curve here in the lower trunk area, lower back area, they should put these straps on lower on the front of that brace. And that will help reduce the curve. And actually it'll help rotate the pelvis a little bit. So the spine is a little bit more straighter, I'm not sure if that was good English or not, but a little bit straighter. And very often that will help alleviate some pain or discomfort. If we're dealing with a person with a very flat back, then we tend to put these straps up very high on the front piece of this back brace. And that will help induce just a little bit of a curve into that spine. And that usually relieves some pain and makes the spine a little bit more functional. So with the same brace, you can address both an excessive curve or a lack of a curve in the lumbar area, just on how you place these elastic straps. Put it on the bottom if you want to reduce the curve, put it on the top if you want to increase the curve just a little bit. And I know it sounds like that's got to be too simple, but it makes a significant difference in the level of support a person can feel from this type of support. Then there are more rigid supports. Some of these have two pulls, and these are usually non-elastic straps that are pulled real tight. So some of these versions have two pulls. This one that is shown in this picture has three. By the way, I did sign a release for them to use my picture here. So wanted you to know that they had signed, I had signed that release. Anyway, what's important here is to have the bottom strap the tightest, and then the middle strap not quite so tight, and the top strap not quite so tight yet. So we create a funnel effect where we get the maximum support on the bottom and gradually just distribute those pressures to support the trunk. The real support for this device, even though it has three straps, the real support comes from that bottom strap. Then we get into the upper trunk area and the kyphotic curve that we talked about, and the exaggerated curve in the thoracic spine. At a minimum, just a trunk posture support like this can be very, very effective. There are straps that go around the front of the shoulder and help pull the shoulder back. That's usually going to be elastic. Some of these are adjustable, where this strap comes around to the front of the shoulder and back over here, and then crosses way over to the front on this side. And you can pull that a little bit more snug if you want to. This one is just all elastic, and for certain situations that can be just great. There are a gazillion varieties of this type of just posture support for the upper trunk. And they can be very effective in early stages of this kyphotic curve. The problem that a lot of people run into with a brace like this is that they think that, oh, that curve isn't bad enough. Yeah, I'm having some pain back there in my back, but it's not real bad. I really don't want to wear a brace. No one goes through adolescence saying, gee, when I get to be an adult, I really want to wear a brace. So that's nobody's goal. But they can offer so much help and support, and they can make a person's life so much easier just by offering that little bit of support. The question that so often comes up, if I wear support, I'm just going to get weaker. And that is absolutely not true. Let me just share a situation with you. If someone has back pain and they sit on their lazy boy chair and that's all they do, and they find a comfortable position on their lazy boy chair, and they don't do hardly any activities at all, are their muscles going to get stronger or weaker? Those muscles will get weaker. It's called disuse atrophy. So if we put a brace on that person and they go back to their chair and they don't change their lifestyle at all, will their muscle get stronger or weaker with the brace on? They'll still get weaker because the muscles aren't being used, secondary to not being used. They'll get weaker. So, but if we put a brace on someone and that person, because of the support that brace offers, and there's a little bit of pain relief, and they feel a little bit more freedom to move, they feel a bit more stable on their feet. If they start doing more and they start pushing a grocery cart through Kroger's, and they start walking the dog, or they start being more active, wearing the brace, they're going to get stronger because their activity level is higher. So don't fall into the trap of thinking that because I'm going to wear a brace, I'm going to get weaker. If you can wear a brace and that brace helps you remain more active, then your muscles will become more strong because you're being more active. So, so that anyway, that's just an upper trunk support. Then there are two very heavy duty kind of supports for the upper trunk. This one has the support, there we go, the support up in front here. And so it's a pretty rigid brace down here for the lumbar area, for the lower back area. And then it has this extension coming up, and there's support on the upper trunk right below the clavicle. And that helps support the upper trunk. So you have support from the front here, trying to push this back a little bit. This brace won't work if a person is carrying a lot of extra a lot extra weight, because or if a person is heavy breasted, this is a real challenge to use because this upright here that would come between the breasts. But this has some applications. The companion to this product supports the upper trunk from the back, but has these straps that come around and they cross the front of the shoulders here, and they help hold the shoulders back and help support the spine from the back instead of from the front. This one is probably more user-friendly in my experience. You don't have those two pads pressing on your chest wall trying to hold you up. This one is pulling you up from the back. It's probably a little bit more comfortable, a little bit more user-friendly. So these straps, this type of brace, however, is contraindicated if someone has had a mastectomy, because these straps could put pressure right on the lymph nodes in here, where if someone's had a mastectomy, those lymph nodes have been interrupted already, and we don't want that strap to create additional disruption to the function of those lymph nodes in front of the armpit area. So, but a really good option for a little bit more advanced kyphotic curve for upper trunk stability. So what makes these braces work? If you get one thing out of this half-hour presentation, take this home with you and keep it in your back pocket. None of these braces will work for the upper trunk, for the lower trunk, for whatever, if the front of the brace doesn't come down to that bone right below your belly button. So here's your belly button's right about here. You feel down to that bone right below the belly button. It's referred to as the symphysis pubis, but you don't need to know that. Just find the bone below your belly button, and the bottom of the brace has to come to that level, or it can't do its job. If the bottom of the brace comes just below your belly button or just over your belt line, it cannot support your spine. It just can't. But just biomechanically, it's impossible. So real critical for the front bottom of the support to come to the level of that bone below your belly button. And in the back, the bottom of the brace in the back should come to the top of the crease of the buttocks. And if it's too high, it can't do its job again. If it's too low, it could dig into furniture and you're not going to love that. So the ideal location is at the top of the crease of the buttocks. Remember those two landmarks. If you're wearing any kind of back support at all, the brace can be more effective. You can optimize rather the effectiveness of the brace if they're fit to those two landmarks. In the fitting process, make sure you put all the straps on snugly, if there are straps. Put them on all snugly, as snug as possible, actually. And then come back a second time and retighten that bottom strap really tight. Then come back and slightly loosen the straps on top of that, so you form this pressure funnel to support the spine. That's where you'll get the maximum comfort and the maximum support out of any of these back braces, is to wear them low enough, but not too low, wear them low enough, and have that bottom strap really nice and snug, and then the rest progressively a little bit less snug to distribute the forces. And finally, if there is a lot of extra soft tissue, put the back brace on while a person is laying down and get them to the right landmarks and so forth. But this helps manage the extra soft tissue. If the person puts it on laying down, they'll end up with a better fit than if they tried to put it on standing up. So I think that's the end of the presentation on spine. Again, as June and Beth mentioned, we'll be hanging around a little bit while after the program to answer questions. So don't hesitate to get those questions in if there are any. So now we're going to go through that same process on the knee. There are four primarily bones: the femur or the thigh bone, the kneecap or the patella, the tibia, which is a shin bone, and the femur sits on the side of the knee here. Just go through this fairly quickly. It's never bone on bone, or it shouldn't be bone on bone. It's cartilage on cartilage. There's cartilage behind this bone here, and it articulates with this bone here. And so it's cartilage on cartilage, which is why joints can move so freely when they're functioning correctly. And the meniscus, the pad between the knees here, is also a cartilage. And you can see they're kind of horseshoe shaped here pads. They give the round head of this joint here, they give that a place to move so it won't slide off the tibia or the shin bone. So it makes the knee a lot more stable with that cartilage there. So that's the meniscus. Four ligaments in the knee, one on the inside joining together the upper and lower leg, one on the outside joining together the upper and lower leg, one to the front of the knee right in the middle, and that keeps the tibia from sliding forward like this. And this guy back here is called the posterior cruciate ligament, the PCL, posterior cruciate ligament. That's the ligament that's involved when there's an issue of knee hyperextension, because this guy's main job is to stop that knee hyperextension. So we'll end up talking more about that. As far as the major muscles in the leg, the quadriceps, you would think there would be 4 of them, but there's actually 5 quadriceps. A little bit of a trick in the naming of that. Hamstrings, there are 3 major hamstrings on the back of the thigh. Then in the calf area, there's 2 major muscles. One of those has 2 bellies to it, so it's split in 2 up here, and then it joins together down lower. So that's one muscle, and then there's another one underneath it. So there's 2 muscles in the calf group, and then one primary muscle in the front of the shin bone, and that's the muscle that picks the foot up during swing. So if someone has foot drop, it's usually this number 4 muscle here in the front of the shin bone, referred to as the anterior tibialis. That's a muscle that's usually involved if there's foot drop. So we're going to focus a little bit on knee hyperextension. Here's normal posture, of course, and here's knee hyperextension. I probably didn't need to show a picture of what that is. And how it occurs is that if someone has a little bit of foot drop and the foot strikes the ground, the knee tends to end up in knee hyperextension. I'll show you a video of that in a minute. And what we'll get to is that there are bracing systems available that help resolve this knee hyperextension issue. So here's a young lady, and she's left side involved. You can see her foot drop there. You can see her knee just being driven into knee hyperextension because of her foot drop. You can't see it very well there. We'll replay this video. Watch it again. Watch this knee. And it's going to be driven into knee hyperextension because, oh, that almost hurts, ouch, because of that foot drop. So very, very common in any of the neuromuscular conditions that can lead to foot drop. There's very common to find associated knee hyperextension issues that need to be dealt with. So for very mild or early knee hyperextension issues, these carbon composite AFOs actually help address the issue of foot drop, and they help address the issues of knee hyperextension. All we do is put a little bit of wedge, and I mean just 1/8 of an inch underneath this foot plate, underneath here and at the heel end, and that changes this angle of this front shell. You see here, there's no AFO showing, and here there's just a tiny smidgen. That's usually all it takes to influence the knee away from knee hyperextension. So here's the same lady you saw, and now this is her very first time walking in this brace, and she's tending to get away from that knee hyperextension because the brace takes away the foot drop issue, and it helps support the knee because it comes up the front of the leg instead of the back. So we usually try and start here if at all possible. In dealing with knee hyperextension, because it's so easy. The brace is super light, and it's kind of springy. It puts spring back in your step a little bit. People feel stable in it, and if it can help resolve the knee at the same time, that's kind of the best of both worlds. So if that isn't quite enough, there's a relatively light-duty pull-on knee sleeve that can work to help control knee hyperextension, and very often that's used along with one of those carbon composite AFOs. So we're picking the foot up during swing and controlling the knee all at the same time. And again, if we can do this with just the AFO, we do that. If we need to go to something stronger, this is very mild intervention. This is a bit more substantial intervention. This is a rigid brace, but it hangs on the leg really well. It doesn't slip down towards the ankle. It's very low profile. If you're wearing slacks, no one would know you're wearing this. And it does stop the knee from going into knee hyperextension. So if there's a case of knee hyperextension without foot drop, this is typically what we'll tend to go to. And finally, if there's significant foot drop and significant knee hyperextension, this is a custom knee orthosis here. custom fit into a very substantial AFO type thing. And that can work for advanced cases of foot drop associated with knee hyperextension. So then there's one other brace I wanted to mention, a healthy knee and an osteoarthritis knee and a rheumatoid arthritis knee. The osteoarthritis knee is an overuse type thing. It's usually going to occur only in one joint, maybe two. Rheumatoid is a systemic disease that involves virtually every joint in the body. And so we'll focus on this osteoarthritis overuse type knee joint. So there are 4 stages, and anybody over 60 is typically going to be at stage 1. I'm a little bit older than 60. I have some arthritis in my knee. It doesn't slow me down at all. No pain, no issues, but it's there on X-ray. And so I know I'm a stage 1. But there are people who get over here, and we'll talk just for real quickly about how to do that. Stage 1, you're not going to do anything. If there's any issues at all, stage 2, just a knee sleeve can do something, help keep the knee warm and help it feel more stable. That's a physiological support. It's not just psychological. So these are medically appropriate. Then if there's advanced stage 2, where the knee starts going into a bow-legged posture like that, this strap here will pull the knee into a more corrected posture. And so that's, again, a very light duty pull-on type knee sleeve. A little bit more advanced, we're into stage 3 and stage 4. This type of brace will push the knee into a corrected posture. So that would be worn here, and this dial here, we could turn that, and that would put additional pressure on the knee to push it into a corrected posture. So there's that type of knee brace. And then there's a pull type for stage 4, stage 3 plus stage 4, where this brace has an upright to the outside. You pull the knee into a corrected posture. These 2 straps here pull the knee over towards this upright. So some real reasonable options for managing OA of the knee. And ultimately, some of us are going to end up where the knee brace isn't enough, and we end up with some joint replacement stuff. Tricks rather in fitting a knee brace, any knee brace, a hyperextension knee brace, or any of them. Anytime you put a knee brace on the knee has a larger circumference at the thigh and smaller circumference at the ankle. So virtually anything you put on the leg is going to want to slide down. So the recommendation is to fit the knee brace. Here's the bone, and here's the brace. Fit the knee brace at 1 inch too high, and then stand up and just take 3 or 4 steps, and it will seat itself down and seat itself on the soft tissue. And you end up with a brace relatively, here we go, here's the joint of the brace, relatively in line with the middle of the tibia in front here, and that would be the proper height. The problem is people put the brace on here, and then they take a few steps and it ends up down here, and the brace ends up way too low. So just start 1 inch too high, anticipating that it is going to seat itself down, and it ends up at the right height. And then as far as the front to back posture, the brace should look like it's about 2/3 to the posterior on the knee. And the reason that makes sense is if we draw this little green dotted line through here, if we eliminate visually the patella, now we see that the brace is about exactly equal front to back on that knee if we just exclude the tibia. Including the tibia, we can, including the tibia, it looks about 2/3 to the posterior. So that would be the correct position for the brace as far as the front to back. And again, 1 inch too high, and then it'll settle down as far as the height. So tricks on fitting a corrective type of knee brace. With that, we've gone over the spine, and I hope you've gotten some tips out of that on how to use these types of braces and what types of braces are available. Same thing on the knee. We looked over some anatomy and types of bracing, and especially knee hyperextension perhaps, and then knee bracing fundamentals. with that, I would like to thank all of you for joining. It's been a pleasure to join you today. This is fun for me. So I hope you derive some useful benefit out of the webinar. Thank you to June and Beth. It was great having you here. Krista actually did a lot of work in setting it up. She wasn't able to help us today. So, but thank you for June and Beth for being here. Our Beth Deloria, that's her right here, does a lot of community outreach, and she does events. She runs a half a marathon before COVID. She ran a half a marathon every weekend, and then every once in a while she'd run a full marathon, and she has totally flaccid foot drop. So she's wearing these braces, and she has teams working with her all over the country that help create promotion to let people know that they don't have to sit at home because they have foot drop. They can be almost as active as they want to be. So thank you, Beth. Thank you, Dr. Apple with Allard. She secured the funding for this. And there's me. There's my email address. If you want to contact me, it's Bob, B-O-B, at kasseledu.com. And with that, yeah, if you want to email me, I'll be happy to answer any questions you might have or provide whatever I can as far as advice. With that, I'm going to step out of here and turn it over to Beth. Did you want me to?
Yes, yeah, if you want to stop sharing your screen, then we can go to gallery mode and people can see you.
Gotcha.
More full size.
Good job.
Great. Well, thank you so much. That was so informative. We really appreciate it. And we have tons of questions, so I'm going to jump right in. Here's one from Deborah. She says, a couple of weeks ago, I started having a lot of pain in my posterior knees, especially on my weakest side. I've even had to start using a walker. She's getting massage and facial release, but that hasn't helped. I don't have hyperextension in my knees, but have some fullness in the posterior knee area without redness. Sounds like maybe some fluid retention or something going on, but yeah. What can we do for her?
My guess is the muscle that stops the knee from going too far into extension, that stops it from going into knee hyperextension, that muscle is called the gastrocnemius. It's a muscle you feel right under the skin in your calf area. If that muscle tends to get weak, then that tends to put pressure on that posterior cruciate ligament that we mentioned, and that's going to create soreness posterior or behind the knee. Now, I haven't seen this person. I'm not a doctor, so I'm certainly in no position to make any kind of diagnosis. But if she could maybe see a physical therapist or a doctor and have the muscles in the calf group tested out, it may be the very early signs of her developing some kind of knee hyperextension kind of issue. So I would do that earlier rather than later. It's not an emergency by any means, but don't wait 5 years to take care of this, because in 5 years there could be a 20-degree knee hyperextension, and that's really hard to manage. So.
Okay. Great. Thank you so much.
You're welcome.
This is a question from Bob. He says, how do you prevent a brace from creeping up? I think he's referring maybe to one of the lumbar support type braces.
That's a good one. Back in the olden days, they used to sell straps that went right from the bottom of the brace in front through the crotch area to the bottom of the brace in the back, and that really did a good job of holding the brace down. They were so incredibly uncomfortable that no one could use them. So I would just encourage him to start with the brace. Encourage Bob to make sure the brace is on at the levels we talked about, the bone below the belly button and so forth. Make sure that bottom strap is really nice and snug, and then gradually less and less compression on the straps. And that should help some. I'm not sure there's a cure, though. You may have to stop and adjust that a couple of times a day.
Okay, great. Thank you. There's a question from Beth, referring, I think, to the type of brace that goes across the upper back.
Yes.
She said, are there ones that are wider to press down on protruding shoulder blades. So there's scapular winging is a very classic issue with FSHD.
Yes. Yep. That the more rigid type of brace that we showed, as opposed to the one that had the two pads sitting up here on the chest wall, one that comes up higher on the back and then has the straps across the front of the shoulder area and come through below the armpit. That's the one that has pads that sit right over the scapula. Will it help with winging? I'm not sure. It'll have some influence to help reduce that a little bit. Will they position the scapula back into a normal position or posture? That's probably doubtful, but it can provide some external support to prevent them from going too far, perhaps.
Mm-hmm. Great, thank you so much.
You're welcome.
Are there braces that are good for hip support only?
Hip support, there probably aren't, but I do want to mention one thing. There's a brand new hip brace. I've never used it. I just saw an ad within the last 2 weeks that there's a hip brace available that's prefabricated for use pre-surgically or to delay surgery. My first try with the hips would be to get what's called an SI belt. That's Sam Isabel SI belt, sacroiliac belt. It's only about 6 inches tall, and it goes around the same landmarks that we talked. In other words, the bottom of that little belt will come to the bone below your belly button, but that will cover the hip area, and it'll just give them a little bit of hug and hold them in some. And I know patients who have benefited from that, and it's by far the simplest and least expensive method of providing some support for the hips.
Great, thank you so much.
You're welcome.
Here's a question from our Facebook audience. Rachel's asking, regarding lordosis, one issue has been the support material rolling or sliding. Is there a way to mitigate this?
Of the brace rolling or sliding?
I guess maybe the elastic material, or
right.
That it
tends
to fold over.
That might be a design defect in the brace that is being used. They shouldn't roll over at all. Yeah, there should be spirals built in to prevent that rolling over. She may have to go to a brace. I'm picturing something very light duty, all elastic type thing. That may have a tendency to roll over and slide. So she may have to go to the next level up. Still a very simple lower back brace, but something a little bit more substantial as far as the material that was used to make the brace.
Mm-hmm. Okay. There's a quick question from Rick. He wanted to know, what is the model or name of the black lumbar support brace you showed with the 3 straps? I wonder if...
that happens to be made by a company called Optec, OPTEC. And honestly, I don't know the trade name of it, but that's the manufacturer.
Okay, Optec.
OPTEC, they're available through any orthotic prosthetic facility. I know they sell to a lot of doctors' offices. So it is pretty widely, they're very widely known in the world of spine.
Okay, great, thank you. Here's a question from Sandra. If I am not holding myself up with walking sticks or a walker, I bend at the waist at about a 45-degree angle. Is there a brace that I can use? Basically, I need something that pushes my upper body up 45 degrees and holds it there.
Without seeing her, I'd want to see her go from sit to stand and see her walking, whatever. So again, I'm definitely not making a diagnosis, and this is just a very broad ballpark kind of answer. There's a probability that most of the braces we've talked about wouldn't help with that severe a trunk instability. And so what may help, and that's even questionable, what may help is a custom molded plastic body jacket. The problem with that issue is that she's bending forward primarily at the hips, and her low back is leaning forward. there's nothing below that to grab onto to help support the upper trunk. And so a body jacket might do. I would tend to see a PM&R physician, a physical medicine and rehab physician. Some people refer to them as physiatrists for that type of situation. And they would have a really good handle to do a thorough evaluation and see if and what kind of brace might be appropriate. And those physicians work with people who make custom braces, and they have a good relationship usually. So I would probably tend to go in that direction.
Okay.
I'm not sure if any of the devices we talked about today would be strong enough down below to hold up that much up above.
Okay. Thank you.
Welcome.
Here's Anne asking, she says, all the neurologists I have seen have been against using a brace. And I went to see an orthotist on my own, but he seemed to be unfamiliar with braces or these type of braces. How can she find an orthotist who is familiar with neuromuscular issues?
Oh my goodness. I think a company like Allard USA, they have a database of their customers throughout the country, throughout the world actually. And so if she would want to call up the 800 number for Allard, ALLARD, Allard USA, the customer service will give her the names of the orthotists in her area that are familiar with this carbon composite type of brace. I feel badly that patients go to doctors and the doctors say, don't wear a brace. And they don't understand that if the patient doesn't wear a brace and they remain totally sedentary, they're going to get weaker. And so if we can get them up in a dynamic carbon composite device and help them walk and help them be more active, then the muscles at least won't atrophy as fast and may get stronger. So it's a huge frustration for me. It has been for many, many years. It's been that way forever.
Okay, great. Thank you.
Welcome.
Here's a question from Sandra with respect to lumbar spinal support braces. If they start at the level of the bone below the belly button in the front and to the top of the crease of the buttocks in the back, is the person going to be able to bend to use the bathroom?
Yes, absolutely. Absolutely, you can. And what will feel different is that normally as the hips bend, when we go from stand to sit, as the hips bend, the pelvis also rotates. And that's just an automatic biomechanical linkage. We don't think about it. It just naturally happens. So because these lower back braces help stabilize the pelvis a little bit, the pelvis won't rotate quite as freely as it did when the hips bend. So it may feel awkward to go from stand to sit, but it's definitely doable. You may want to have someone give you some hand support or something the first time you sit down in a chair even. So it's just awkward, but it's definitely doable. As you do it more and more, you gain range of motion in your hips. The pelvis appreciates that it's not going to get to rotate as much as it used to. And within 3 or 4 days, it becomes more natural or normal. But that first day wearing a brace and trying to sit down, it just feels awkward. It's definitely doable.
Okay, thank you. A question here is, do you need a prescription for the types of braces that you showed, and where can they be obtained?
Some of the light duty braces can be just ordered online, or I think Walmart has some of these upper trunk posture supports, not orthoses, but posture supports. So those are pretty readily available in pharmacies and home health stores or whatever. Some of the more rigid devices that we showed this course probably would need a prescription, and they would fit either in a doctor's office or in an orthotic prosthetic facility, and that's what they do for their living. That's what they do is these braces. So
Great.
of the
Here,
two,
oh yes.
Of the two, you might get a better fit by people trained to do the fitting in an orthotic prosthetic facility. There are personnel in some doctors' offices who fit the braces who haven't been trained to fit the braces. And that's another one of my pet peeves. So,
All right. Here's a question regarding knee problems that are not related to foot drop. So there's a couple of patients here saying they do not have foot drop, but they're developing knee problems because of muscle weakness. I think in FSHD, sometimes the quad and hamstrings are affected.
okay.
And
Yeah. Boy, that covers a whole gauntlet of potential issues. If the quads and hamstrings are starting to get weak, a person might tend to start not getting as much knee extension. The knees may stay bent too much, and that feels unstable. And so because that feels unstable, the patient will just guard and they'll kind of lock their knees into extension and not let them bend at all. I'm really hesitant to say much about that, other than I would probably go to a good neurologist or even orthopedist, but probably a neurologist, to have those muscles evaluated, and they would have a pretty good idea of what kind of bracing would be appropriate.
another very common issue with FSHD is weakening of abdominal muscles that can cause what some might say a pot belly or pregnant look. And I think,
Yes.
Are there braces that can draw in those, loose, weakened abdominal muscles
Yep.
and that can be worn under clothes?
Absolutely. Again, I think if you can buy pretty good supportive braces online without a script. I don't think that's anything anyone would need to go to a physician to get a script for. So there are a number of resources online where people can buy product and just have a good idea of your measurements from that bone below the belly button to the bottom of your rib cage. And if you take that measurement, then you can go online and see the measurement of the brace that you're interested in and make sure it's about an inch or two longer than that measurement. So you want the brace to be longer than the bottom of your rib cage. You want it to come up just 2 or 3 inches onto the rib cage, and that will capture the abdominal area. And again, that's one of the braces you would put on laying down, because gravity will help reduce that belly that's hanging out there. And so if you put the brace laying down, then you can stand up, and the brace will help contain the tummy.
Okay. Great. There's a question, I'm not sure I totally understand, but it's, would you recommend the knee brace for foot drop that doesn't involve knee hyperextension?
No.
Okay.
No, you would.
That was simple.
Yeah, I love the carbon composite devices to manage foot drop, but if there's no knee issue, it doesn't need to be braced prophylactically. That would provide no benefit.
Okay. Here's a somewhat related kind of question. I have recently started wearing an ankle brace to reduce instability from FSHD and enable me to walk further. The instability has led to a knock knee. Would it be worth wearing a knee support for this issue too?
Yeah, if there's a knock knee type issue, there's, depending on the degree to which that is happening, if it's relatively mild or relatively early in the progression, you can use the carbon composite devices I showed, but have a foot orthotic on top of the foot plate that will reduce how much the feet roll in. If we reduce how much the feet roll in, that reduces how much the knees come together into a knock knee kind of posture. So early in the stage, we can control that from the bottom up, control the knee posture from the bottom up, and that would be by far preferable than going straight to a knee brace. If it's more advanced, then yeah, they might have to consider wearing the AFO in combination with a brace that's going to help resolve the knock knee posture.
Okay. Great. I have a question from Christine. I have started to walk with what I feel to be a limp with my right hip dropping, but the physio therapist said I have slight foot drop in my right foot. Would an AFO help stop the limp? So
Yes, but watch what AFO is used. If they're considering a molded plastic AFO that comes along, that comes on the bottom of the foot and comes up around the calf area, that style of AFO would probably make her situation worse. I've seen that happen too many times. So make sure she gets the AFO that's carbon fiber foot plate, and then a strut that comes up to the front of the shin. And that will help resolve the foot drop, and it will help support the muscles that are weak, and it'll help improve the spring in her step. And that's what helps resolve the limp, is restoring the spring in her step. A plastic device can't do that. These carbon devices act like a diving board in the swimming pool. They load potential energy, and then they help spring the foot up off the floor. And so that would definitely be indicated for that type of situation.
great, thank you. From Linda, she says, I have advanced lordosis with weak muscles around my rib cage. My waist is much smaller than hips, and I use a custom-made corset that is very form-fitting, but it's not getting rid of the lordosis enough. It goes from the buttocks to just below the breast. Any suggestions on something better, or a suggestion for brace companies to contact for a custom brace?
Wow. I can picture her situation. Yeah, wow. I don't even know who to contact. Try Allard. Allard USA, they may have resources to direct the patient to somebody who does custom back braces. It sounds like that's what's going to be indicated. But there's some off-the-shelf devices that are very rigid that can be customized to do the same job as a custom brace. So it's, yeah, try calling Allard. The other option would be to try and call, look up in the yellow pages or online, the orthotic prosthetic facilities in the area, and ask those people, if you had this situation, who would you go to get it resolved? And see who they would recommend for a fairly supportive or a custom spinal support.
Okay. What brace would be best for those of us who sit most of the day? Is there anything that would keep you sitting up straight? And I guess comfortably is probably the unasked part of that question.
Yeah. Again, I think that's going to depend on the degree of instability in the upper trunk. There's some really, really nice just posture supports that are easy to get on. They're elastic. Some of them are adjustable, where you can support the trunk a little bit better. If it's totally just upper extremity scapular area, that might be one type of support. If it goes down lower into the thoracic spine and maybe even close to the lumbar area, you may have to grab the trunk down low in order to provide the stability for what's sitting on top of that. So I guess depending on the degree of instability, the greater the level of instability, the lower down you would have to go to create a foundation to help support the upper extremity, the upper trunk rather.
Okay. Here's a question, could a shoulder brace help pain in my head? I think she might be perhaps referring to pain that comes from muscle weakness and effects on shoulders and neck.
Yes, definitely. Yep. If the shoulders are guarding and the neck is trying to compensate for that, everything just gets tight because it's just locked down and guarding as best it can. And so having some external support can definitely support the posture of the head and neck.
This question, following up about custom braces. She wants to know, what material are they usually made from? Do they typically fit from neck to the bottom? And have you seen patients experience noticeable assistance from custom-made braces?
I have. I've seen individuals who probably wouldn't be outside functioning if they weren't wearing a brace. I would definitely, in that situation, start with a physiatrist, a physical medicine rehab doctor, or a neurologist. And they should have good contacts in the orthotic prosthetic community on who does what kind of bracing, who's proficient at doing what. And I would rely on the physician's direction to get the brace that was best suited for his diagnosis.
Okay. And I think we have time for one more. Is there anything for feet that roll outwards and muscles so weak that hyperextension is the only way to stand, even while holding onto the walker?
Was that question the brace for? Is there a brace for the feet?
Yes. What if they roll outward? I guess so. It sounds like it's not exactly a foot drop, but another.
Okay.
Maybe they are curling.
Yes. Yep. Yeah, you're probably describing my foot, actually. It's a real rigid foot, real high, super high arch. Everything is clawed. Yeah, that carbon composite AFO in conjunction with a custom foot orthotic on top of the foot plate, so we can help manage the foot and make the foot do more what it's supposed to do. And then the tibia is cradled in the shell of the carbon composite devices. And that helps alignment from the top down to the bottom. So you're correcting the posture of the foot from the bottom up and gaining some correction from the top down as far as the tibia being directed directly towards the foot. And that's probably the best combination for really advanced foot deformities leading to instability during even just standing.
Great. Thank you so much. Well, we are at the end of the hour, and that was, wow, what an information-packed session. Thank you so much. I'll bring back Beth now to close out our day, our hour.
Hey, Beth.
Yeah, hi, that was awesome. Thank you so much, Bob.
Thank you.
And thank you everyone for attending our FSHD University webinar today. To Allard USA, our educational sponsor, and obviously a very special thank you to Bob Meier for taking the time to be with us today, for the amazing information, answering all of our questions. Just thank you, Bob. That was really great. We appreciate you very much.
Happy to do it. Thank
Okay,
you.
everybody, our next FSHDU webinar is on Thursday, January the 21st at our regular time of 1 p.m. Eastern. Our topic is going to be MRI in FSHD research, so should be pretty interesting. These webinars are scheduled for the third Thursday of every month from 1 to 2 o'clock Eastern, so be sure to mark your calendar. Coming up later in December on the 29th at 8 o'clock Eastern is our Caregiver Sharegiver Hour, specifically for those of you that are providing care to loved ones with FSH. So join in if you are a caregiver or a sharegiver, as we call them. And lastly, our radio show featuring Tim Hollenbach is taking a holiday break, but he will start back up again on January the 12th. There's going to be 2 changes to the show that I mentioned earlier today. In the new year, we've moved to Tuesdays 2 times a month, and we'll be live streaming over YouTube rather than Facebook. So if you don't follow us on our YouTube channel, please do so you can receive updates about these live stream events, okay? And then as always, check our website, events calendar for all of these upcoming events, local chapter events, everything, and watch your email for all the updates. Again, thank you, Bob. Thank you, everyone, for joining us today, and we will see you next time. Bye, everybody. Happy holidays. Thank you.
Thanks so much. Merry Christmas.